Right. Yeah. Sorry for the delay, and I am Dr. Sarath Balaji on behalf of PW MedEd. So, what is this? Actually, this session is meant for. This is a masterclass session. Right now, you have been seeing and you have been witnessing so many classes on theory, but how many of you are teaching practical backgrounds? So, I am Dr. Sarath Balaji. Today, let us start my master class on pediatrics, and we are going to focus on pediatric pulmonology right now. In the subsequent series, we will be concentrating on other systems also. As a third year or fourth year, it will be difficult for you to find out, if at all you see, if at all you hear some sound, from where it is coming, in which system is involved, whether it is an upper respiratory tract or lower respiratory tract. You must be worried what the child what the problem the child has been suffering from. But also, medicine is nothing but a mathematics. If you apply simple concepts of anatomy, physiology, inspection, and clinical examination, it will be very, very easy to identify where the site of pathology and where the what is the etiology behind it. So, in the next 30 to 40 minutes, I am going to teach you some simple case-based scenarios. I am going to show some videos. Based on the videos, by seeing, by looking, and by hearing, you can identify by yourself, by third year or fourth year or fifth year itself, you can identify both the site of pathology as well as the etiology. Okay, so let's have a simple approach to pediatric pulmonology for today. Right. So, what is this approach? When mother says something, you are listening to the mother. Point number one. Second point is you are seeing something with respect to the child. With this, is it possible to find out the problem? The answer is yes. So let us go to series of videos so that you can identify it. So what are all the complaints that a child can brought with by the mother? The child can brought with the noisy breathing. Sound is coming from the nose or coming from the throat or coming from the chest. The mother may say that my child is having some throat pain. The child can present with fever. The child can present with cough. The child can present with breathlessness. So these are all the only 5 complaints with respect to pulmonology. I repeat, one is noisy breathing, the second one is throat pain, third one is fever, fourth one is cough, fifth one is breathlessness. These are all the simple complaints the mother is going to deliver to the doctor. So now, what are all the sites you have? You have nose, you have nasopharynx, you have larynx, you have vocal cord, you have trachea, you have bronchus, you have alveoli, you have interstitium, you have pleura, and you have chest wall. So the symptoms are just 4 to 5, but the sites are many, starting from nose up to pleura. Now, based on the symptoms and clinical examination, how you are going to decode the underlying problem, let's see. Okay, so to start with, this is the cut section of the, what is that, head and neck. So this is the cut section of the head and neck. So let me show one video. So listen to this audio and tell me where is the site of pathology. So listen to this audio. So you could hear some sound. You could hear some sound. It is low pitched sound, heard mainly over the nose. So what is this sound called? This sound is called stertor. I repeat, this sound is called stertor. Stertor. Stertor is nothing but a low pitched inspiratory sound that occurs as a result of presence of secretions in the nose. Presence of secretions in the nose. Low pitched inspiratory sound due to the presence of secretions in the nose, that is called stertor, right? So this is the first sound is called stertor, right? Then the next sound. So what is this next sound? Look at the next sound. So look at this video. Look at the noisy breathing that you can hear. There is a little bit of frothing from the mouth. This is also an inspiratory sound, and the pitch of the inspiratory sound is more compared to the previous one. So what is this? The child is sleeping. So again, this is an inspiratory sound. It is high pitched, more during sleep, and the child is opening the mouth, leading to frothing. In the first instance, the site of pathology is in the nose, but here the site of pathology is in the nasopharynx. So what is this sound called as? This sound is nothing but snoring. Snoring indicates that the site of pathology is in the nasopharynx, and the most common etiology for snoring in child is adenoid unless otherwise proved. Okay, so this is snoring and the site of pathology is nasopharynx and the etiology is adenoid. So remember one point, both stertor and snoring usually occurs only during sleep. Why? Because whenever you sleep, what will happen? You will close the mouth automatically, as a result of which air will be finding difficult to pass through the nose as well as through the nasopharynx when there is an obstruction. So remember, whenever you have noisy breathing only during sleep, either it can be presence of secretions in the nose, that is called stertor, which is low pitched, or it can be due to high pitched snoring sound which occurs as a result of obstruction at the nasopharynx. Otherwise it is due to what? Adenoid. So during sleep, low pitched sound is stertor, high pitched sound is snoring. Snoring unless otherwise proved in pediatric age group, it is called adenoid. Okay, right. So these are all the two inspiratory noises that occurs mainly during sleep. Then comes your, so these are all low pitch. So snoring a little bit medium pitch. Now look at this sound. Now look and listen to this sound, my dear boys and girls. Look at this sound. Look at this sound. So what is this? High pitched sound and the child is awake. I repeat, that high pitched sound and the child is awake. So where is the site of pathology? So whenever the noisy breathing occurs only during sleep, it is occurring above the level of the larynx, because when you open the mouth during sleep, it will disappear. But this sound, whether the child sleeps or not, the sound is not disappearing, because the level of lesion is larynx. I repeat, the level of lesion is what? Larynx. So this high pitched sound, I repeat, this high pitched inspiratory sound occurs due to the obstruction at the level of the larynx. You all know that in pediatrics there is one condition called laryngomalacia, in which your epiglottis, your epiglottis, your airy epiglottic fold and arytenoid will be very soft for a period of time. During that time, what will happen? This epiglottis and arytenoid will fall into the laryngeal inlet and causing obstruction during inspiration. So this is called laryngeal stridor. So in a well appearing infant with inspiratory stridor, it is unless otherwise proved laryngomalacia. I repeat, a well appearing child with the on and off stridor and the child seems to be normal and it is inspiratory in nature, this is called laryngomalacia. Okay, what are all the other causes that you can get this kind of stridor? Sometimes you would have heard about ALTB, acute laryngotracheobronchitis. So what is this acute laryngotracheobronchitis? Whenever you have some viral infection, most commonly para influenza, there will be edema of the glottis and subglottic, leading to inspiratory stridor for time from time being. So the most common congenital cause for stridor is laryngomalacia, whereas the most common acquired cause of stridor is, what is that? ALTB, or acute laryngotracheobronchitis. Again here the site of pathology is in larynx. And what is the difference between stertor, snoring and stridor? Stertor and snoring disappears, present only during sleep. Okay, whenever you open the mouth, the sound disappears. Whereas in stridor, the site of pathology is here. So both during awake as well as during sleep, the sound will be there. That's how you differentiate stertor, snoring, and stridor. Stridor, most common congenital cause is laryngomalacia. Most common acquired cause is ALTB or acute laryngotracheobronchitis, otherwise known as CROUP. That is called as what? Croup. Right? So the site of obstruction is larynx. So this is the third noisy breathing. And what retractions you are seeing here? Look at this. What is the retractions here? You are seeing this. Look at this. Where is the retraction you are seeing? Where is the retraction you are seeing? You are seeing retractions over this area. This area is called as what? Suprasternal area. So suprasternal area means suprasternal retractions means the site of pathology is immediately below the place where retractions are present. So I repeat, suprasternal retraction is equal to laryngeal obstruction. Inspiratory stridor is equal to laryngeal obstruction. That's all. So it doesn't mean that you need to take an X-ray, you need to take a CT scan, you need to take an MRI, you need to take a flexible bronchoscopy. By just looking at the child, looking for the retractions, by listening to the sound, you can very well make what the child is suffering from. That is the beauty of a clinician. That is the beauty of this masterclass series. Right? Then look at this sound. First one is stertor, minimal intensity. Second one is snoring, again a little bit of higher intensity, only during sleep. Both during daytime and nighttime is stridor, little bit of high pitched stridor. These are all inspiratory sounds. But now look at this sound that I am going to play right now. What is this sound? Is it during inspiration or expiration or both? I repeat, is it during inspiration or expiration or both? So what does it mean? It is present both during inspiration and the expiration. Whenever you could hear sounds, noisy breathing, both during inspiration and expiration, it is called as what? Biphasic stridor. What is that called as? Biphasic stridor. Biphasic stridor usually occurs whenever there is a pathology in the subglottis region. I repeat, whenever there is a pathology in the subglottis region, because subglottis is the narrowest part in the pediatric population. So whenever you hear both inspiratory and expiratory sound, the site of pathology is subglottis. Okay, this is called biphasic stridor. So what are all the causes for biphasic stridor? You all know that majority of our children are right now surviving even when they develop respiratory failure. Why? Because we often intubate the child. But at times what will happen? This intubation will produce some kind of injury to the subglottis, and due to that some granulation tissue will be produced in the subglottis, leading to presence of subglottic stenosis. This is called acquired subglottic stenosis that arises as a result of what? Previous intubation. So I repeat, for a undergraduate, listening to both an inspiratory and expiratory sound is subglottic stenosis. Either it can be rarely due to congenital, or most commonly it is due to acquired. So biphasic stridor is subglottic pathology unless otherwise proved. Okay, right. So here also you will find some suprasternal retractions. Okay, subglottic pathology. Now look at this video, the loudest sound that you can hear right now. The loudest sound, loud, very loud, very loud. Look here, very loud. Suprasternal retractions. I am playing it right now, very loud. What is this? What is this? So whenever you hear a stridor, that can be heard even from a distant place. That means what? You are here, you are listening to one sound, inspiratory sound, and the child is some 500 meters beyond our place. Despite that, if you hear that sound, that is the loudest inspiratory sound. So in which condition this loudest inspiratory sound comes? The answer is very simple. I have put one video of flexible bronchoscopy. Look at this video. Look at this. The vocal cords. Look at the vocal cords. Normally vocal cords should abduct and adduct. Look at me. The vocal cord should abduct and adduct. Look at this video. The vocal cords are not at all abducting. The vocal cords are not at all abducting. So abduction should be proper. Here the vocal cords are not moving. So what does it mean? This is called bilateral abductor palsy. So this is called as what? Bilateral abductor palsy. So the loudest stridor that you can hear with the normal intact voice is bilateral abductor palsy or recurrent laryngeal nerve palsy. Okay. I repeat again, the loudest inspiratory sound with the normal intact voice is bilateral abductor palsy. Whereas in unilateral abductor palsy, there will be only hoarseness of voice. In unilateral abductor palsy, there will be hoarseness of voice. Whereas in bilateral abductor palsy, you will have a loudest stridor with the intact voice. Very, very important. What? Intact voice. So, what are all the things we have heard? Stertor, snoring, and then stridor, in biphasic stridor, a vocal cord palsy. What is the manifestation? Now, so loudest stridor with intact voice is bilateral abductor palsy. Now comes. So these are all the sounds. Now let me show you some interesting cough videos. So look at this video. Look at this video. Look at this video. The boy is coughing like anything. The boy is coughing like anything. Look at this. Look at the girl child also. The girl baby is also coughing like anything. So what is this? Is this here spotted? So what is this? Again, look at this. Whenever they cough, both of them developing redness of face and tears from eyes. I repeat, both of them are developing redness of face and tears from eyes. And one more important point. What is that important point? They don't have breathing in between normal breathing. They develop continuous coughing. So how about their cough? Look at me. So this continuous boots of cough without normal intervening respiration is called as paroxysmal cough. What is this called as? Paroxysmal cough. And again look at me. When this cough is followed by so what is this? This cough followed by inspiratory whoop. So what is the diagnosis? This is called whooping cough, otherwise known as pertussis. So what is the diagnostic criteria for pertussis or whooping cough? The diagnosis criteria for pertussis is very simple. Whenever you develop paroxysmal cough, what do you mean by paroxysmal cough? Cough occurs in boots without any intervening respiration in between, and it is followed by either that whoop sound. Sometimes it will be associated with post-tussive vomiting, coughing, followed by vomiting. This is called post-tussive vomiting. So paroxysmal, post-tussive vomiting and inspiratory whoop. Whenever any child is present with, your diagnosis should be pertussis unless otherwise proved. What is that? Your diagnosis is pertussis unless otherwise proved. So what is the organism? You all know pertussis is caused by Bordetella pertussis. We have vaccination at 6 weeks, 10 weeks, 14 weeks, 1.5 years, 5 years, 5 years. Sometimes even in IAP they have recommended at 10 years also. Whenever you don't put pertussis vaccine, there are high chances for you to develop this whooping cough. So WHO criteria is paroxysmal, post-tussive vomiting, whoop. But what I would like to teach you, okay, remember, both of them are developing redness of face and tears from eyes. Any child, any boy, any girl, whether it is a 2-year-old or 2-day old or 20-day old or 60 days old, 60 days old, if cough is associated with redness of face and tears from eyes, it is pertussis or whooping cough unless otherwise proved. So remember this point in your mind, in your hippocampus. Definitely within 1 month from now, you will diagnose at least one case of pertussis either in the pediatric age group or in the adult age group. I bet. Okay, right. Then next, so again, you have heard a typical cough. You have heard about a typical cough, some patterns of cough in your theory book. Let me show you one beautiful cough. You tell me what is the answer. So, what is this cough pattern? So, this is the cough pattern. I repeat, so this is the cough pattern. So this is the cough pattern. So what is the difference between the previous cough and the present cough? The previous cough is mainly there is no intervening breathing in between. So how about the pertussis cough? So this is pertussis cough. Look at this cough. So the child is coughing for each and every single breath. I repeat, the child is coughing for each and every single breath. So this is called as what? Come on. This is called staccato cough. This is called as what? Staccato cough, and this occurs due to chlamydia infection. This occurs due to what? Chlamydia infection, and this is called as staccato cough. This occurs due to chlamydial infection, right? This is called staccato cough. So what does it mean? Without even doing a single investigation, by looking at the child, by listening to the sound, you can make a diagnosis on your own and start the medicine. Remember, in both paroxysmal cough produced by pertussis and this staccato cough produced by chlamydia, the drug of choice is not penicillin group of drugs. The drug of choice is macrolide. So what are all the macrolide antibiotics? Your azithromycin, clarithromycin, erythromycin. Erythromycin you need to give 4 times daily, we are not following. Clarithromycin you need to give 2 times daily, and it is costly, not available in many places, not affordable to many. So the drug of choice for both staccato cough and pertussis is azithromycin. There is a vaccine for pertussis, but we don't have any vaccines for chlamydia. Remember, by giving azithromycin, it may reduce the intensity of cough. I repeat, it may reduce the intensity of cough. That's why people used to say pertussis is nothing but a 100-day cough. When pertussis comes, whether you treat it or not, you will be coughing for the next 3 months. It will resolve on its own. The more earlier to start the medicine, the better the recovery time will be. The better the recovery time will be. Okay, this is about pertussis and chlamydia, right? Now, so stertor, snoring, stridor, biphasic stridor, loudest stridor, pertussoid cough, staccato cough. 7 clinical points you were taught. Suprasternal retractions means the site of pathology is over the larynx. Okay, now look at the video. Look at the retractions here. Look at the retractions here. So where is this retraction? Where is this retraction? Look at this. The child is having some retractions. So where is this retraction? This is intercostal retraction. What is this, my dear boys and girls? This is called intercostal retractions. What does intercostal retractions means? Again, the site of pathology is immediately behind the place where retractions are present. Now look at the sound. So now look at the sound. So is this inspiratory or expiratory? The previous sounds are all inspiratory, but this sound is expiratory. And look at the child is somewhat leaning over the mother's chest or mother's lap. The child seems to be sick. So now I have an expiratory sound with intercostal retraction. So what does it mean? So it means intercostal retractions. It means pulmonary parenchyma. It means pulmonary parenchyma, or otherwise known as alveoli, is involved. So what, in which condition alveoli will be involved? Pneumonia. Pneumonia is the condition in which you will have alveolar involvement. And what is this expiratory sound called as? This expiratory sound is called as grunting. I repeat, this expiratory sound is called as what? Grunting. So intercostal retraction is equal to parenchymal pathology, or otherwise known as alveolar pathology. For an undergraduate, whenever any sick child with intercostal retraction comes along with the grunting, your diagnosis should be pneumonia. And remember, grunting is a danger sign. You need to admit the child and you need to start the child on IV antibiotics and oxygen. Okay, this is called as what? Grunting. What is this retraction? Intercostal retraction. So where is the site of pathology? Parenchyma. That is alveoli. Okay, now the previous child was sick, but look at the present child. Look at the present child. The child is having subcostal retractions. The child is having subcostal retraction. The child is having subcostal retractions. So whenever you have a subcostal retraction, whenever you have an expiratory sound, and whenever the child is non-toxic, the problem is in the obstruction is at the level of the bronchus. What is the obstruction? Is the level of the bronchus. So what are all the conditions in which you will get? Only two conditions for your undergraduate level. One is asthma. Asthma, you all know, expiratory airway obstruction. So you will have wheeze with different pitches. Wheeze is an expiratory sound. I repeat, my dear boys and girls, wheeze is an expiratory sound. So here one pitch, here one pitch, here one pitch, here one pitch. So different pitches at different areas of the chest is asthma, expiratory airway obstruction. But sometimes the child would have swallowed a foreign body. It is more common in children less than 3 years of age. They would have swallowed from aspirated from foreign body, most commonly groundnut. That groundnut will go and reside in the bronchus. The groundnut will go and reside in the bronchus, leading to what? Monophonic wheeze. In our first instant, I told you, you will hear different pitches of sound over different areas of chest. But here, same wheeze will be heard over any part of the chest, like this. So if you hear same note of, same pitch of wheeze throughout the entire chest, it is foreign body unless otherwise proved. So remember, subcostal retraction is equal to expiratory airway obstruction. That can be, your expiratory sound can be two things: sick child, non-sick child. Sick child, it is called grunting. Non-sick child, it is called as what? Wheeze. And in wheeze we have two things. One is monophonic wheeze, another is polyphonic wheeze. Monophonic wheeze is mainly due to more foreign body obstruction, whereas polyphonic wheeze is due to asthma. Okay, very easy, right? Then okay, so in the previous scenarios, you have seen cases in which you saw some retractions. You saw some what? Retractions here, and the child is having some kind of noisy breathing. I'll show you one video in which the child is having hypoxia, but there is no retractions at all. So what is this? Look at this. Look at this. Look at this. There are some precardial activity you are seeing. There is some precardial activity you are seeing. Look at the saturation. The saturation is just 55. You all know that whenever you have hypoxia, you need to have some retractions, but there are no chest retractions at all. What is this? There are no chest retractions at all. Whenever you have some hypoxia, your body should act in such a way that it should try to produce some air into the lung, as a result of which some kind of improvement in oxygenation occur. But here, despite hypoxia, the child is not having any retractions. This is called as what? His brain is not sending signals to the muscles. I repeat, the brain is not sending signals to the muscles. This is called as Ondin's curse. This is called as what? Ondin's curse. You would have heard about a story regarding Ondin's curse. Someone would have cursed, whenever you sleep, you will die because you will not breathe. So this is called Ondin curse, otherwise known as congenital central hypoventilation. But for my undergraduates, the one thing that you need to learn is all hypoxia should be associated with some retractions of the chest that we had witnessed in the previous videos. But here there is no retraction. Hypoxia, cyanosis, no retraction is called as what? Ondin's curse. What is Ondin's curse? The medullary center or cortical center is not sending triggering triggers to the either medullary center or to the respiratory muscles. So this is called Ondin's curse, right? The next one. So now, what is this? The child is sick. The next case scenario, the child is sick. The child is having deep breathing. Is there any retractions? Look at this. Look at this. What is this? What is this? What is this? What is this breathing called? You can comment. What is this breathing called as? This is called as deep breathing without retractions. In the previous, there is no retractions. Here, there is deep breathing, but there is no chest indrawing. What is this called as? This is present when a child is presenting from acidosis. What is this breathing called as? This is called as Kussmaul breathing. What is this? This is called as Kussmaul breathing or acidotic breathing. Look at this again, one more child. Again, one more child. Look at this. Look at this. Sugar value is very, very high. Sugar value is very, very high. This is called acidotic breathing or Kussmaul breathing. So whenever the child develops tachypnea without retraction is called as what? Kussmaul breathing. What is called Ondin's curse? Hypoxia without retractions. Hypoxia without retractions is Ondin's curse. Tachypnea without the retractions is acidotic breathing or Kussmaul breathing. So again, very simple. Am I doing any clinical test? Am I doing any X-ray? Am I doing any CT scan? But you are diagnosing so many diseases based on simple clinical examination using your special senses. You don't need an artificial intelligence. Your eye is an artificial intelligence. Your ear is an artificial intelligence. You need to use it judiciously. Okay, right. So this is Kussmaul breathing. Next, what is this? 2-year-old sudden onset cough. 2-year-old sudden onset cough. So what you are seeing here, whenever any child is brought with sudden onset cough in pediatrics, unless otherwise proved, the diagnosis is foreign body. The diagnosis is foreign body aspiration unless otherwise proved in pediatric age group. So I have shown you one X-ray on the picture. Look at the X-ray. Whenever you see any X-ray with a sudden onset cough, what you need to infer? You need to compare the volume of the lung and you need to compare the aeration of the lung. Volume of the lung means what? Whether the right lung volume is equal to left lung volume. Normally, right lung volume and left lung volume should be equal. But here, which one is more? Right lung volume is more. Yes or no? Yes. And remember one more point. What is that? Aeration. Aeration means what? How much air goes inside the lung. How do you know that? The more the blackiness of the lung, the more the aeration will be. That also should be comparable. The right lung should be comparable to the left lung. But here, look here, the volume is more on the right side as well as the aeration is more on the right side. Why is it so? This is called obstructive emphysema. This is called as what? Obstructive emphysema. The groundnut or the foreign body goes and lodges in the bronchus. During inspiration, it is an active process. The air goes inside the lung. Expiration is a passive process. But during that passive process, air cannot come out. So air goes inside, cannot come out. Air goes inside, cannot come out. The foreign body acts as a ball valve mechanism. And this typical picture of obstructive emphysema is suggestive of what? Foreign body in the bronchus. If you want to see in your fiber optic bronchoscope, you can put a bronchoscopy and look here. Look here, what is this? Look here, the groundnut is lodged in the right main bronchus. Now you know why it is due to. The groundnut is lodging in the right main bronchus. Okay, it is lodged in the right main bronchus. Right. So this is about foreign body. Again, what is this? What is this? Again, it was taught to you just now. This child is coughing like anything. There is a redness of eyes and tears from face. So what is this? Again, this is a case of pertussis. Okay. So right now this is more than enough. Again, let me tell you a simple revision. Let me conclude with a simple revision. So what is that simple revision? Whenever you have stertor, what is called stertor? You have noisy breathing during inspiration. Noisy breathing due to inspiration. The site of obstruction is nose. Second one, what is called as? The second one is snoring. Second one is snoring. Where is the site of obstruction? Again, this is an inspiratory sound. Again, this is an inspiratory sound. So, what is the pathology? Adenoid. What is the site? Nasopharynx. What is the site? Nasopharynx. Nasopharynx. Next, what is that? Stridor. Next one is stridor. Again, what is that? Inspiratory. Stridor is inspiratory. Where is the site of pathology? Larynx. Next one, biphasic stridor. Next one is called as what? Biphasic stridor. Biphasic stridor, both inspiratory and expiratory sound. Where is the site of pathology? Subglottis. Where is the site of pathology? Subglottis. And expiratory sounds are grunting. The child is sick. It is expiratory sound. And parenchymal pathology. Parenchymal pathology, that is known as pneumonia. And finally, you have grunting and then wheeze. Wheeze, the child is usually non-sick. It can be either monophonic wheeze, it is foreign body, whereas polyphonic wheeze, it is due to what? Polyphonic wheeze, it is due to what? Asthma. That's all, very easy. And one more point, asthma. So this is very easy. And then with respect to retractions, suprasternal retractions, suggestive of what? Laryngeal pathology. Whereas intercostal retractions are suggestive of what? Parenchymal pathology. Subcostal retractions is what? Expiratory airway obstruction. Expiratory airway obstruction. When you have hypoxia without retractions, it is called Ondin's curse. Whenever you have hypoxia, whenever you have retractions without, Tachypnea without retractions. Whenever you have tachypnea without retractions, it is called Kussmaul breathing. Kussmaul breathing. So, how it is easy to identify based on your special senses? So, hereafter, when you want to attend a pediatric pulmonology case, suprasternal, sternal, intercostal retraction, inspiratory, expiratory sound, hypoxia is there or not, retractions is there or not, based on that almost 10 diagnoses you can get. Coughing without intervening breathing is pertussis. Coughing with each and every breath is chlamydia. Sudden onset cough is foreign body. So this master class is over for today. So please make a note of it. In the next subsequent session, I will be teaching some simple clinical concepts on pediatrics. Bye bye.